You know, pediatric patients are not just tiny adults. Their physiology is completely unique, and that means their emergency presentations are unique too. Welcome to this explainer. Today, we're tackling the pediatric neuro and musculoskeletal systems, but we're doing it purely through the lens of NCLEX priorities and clinical safety. We're going to break down exactly what to look for and how to spot those tricky test questions from a mile away. Let's dive right in. Let's kick things off with a classic test trap. So imagine an infant comes into the ED with profound muscle weakness. The parents mention, oh, we've been adding local organic honey to the baby's bottle to soothe the cough. Okay, what is your absolute priority here? What do you do first? Your priority is recognizing botulism right away. You really want to burn the image of a floppy baby into your memory. For any baby under 1 year old, if you see constipation, weak swallowing, a weak cry, and decreased muscle tone, that is a massive red flag. The botulism pathogen absolutely thrives in honey. So use this quick memory trick. No honey for the bunny. Seriously, keep it far, far away from babies under 1. To properly chunk this information for your exams, we'll flow through 4 key areas today: neuroemergencies, musculoskeletal traps, congenital defects, a mini NCLEX scenario, and a rapid recap. Section 1, neuroemergencies. These are high-stakes situations where rapid assessment literally saves lives. One of the most terrifying moments for a parent is a febrile seizure. For kids aged 6 months to 5 years, a sudden temperature spike, specifically anything over 38 degrees Celsius or 100.4 Fahrenheit, can trigger stiffening, jerking, or even a loss of consciousness. So what's your priority? You need to find the underlying cause of that fever and safely but quickly reduce the temperature. Next up, we have the ventriculoperitoneal, or VP shunt. This is the primary surgical treatment for hydrocephalus, which is that dangerous buildup of cerebrospinal fluid in the brain. When you're assessing an infant, look for specific pattern recognition cues. We're talking an abnormally large head size, bulging fontanelles, and those downward deviated eyes, often called the setting sun sign. The shunt literally acts like a drain, moving that excess fluid from the brain down into the belly. Now, because an infant's skull plates don't fully fuse until they're about 1 to 2 years old, their response to trauma is pretty unique. You absolutely must monitor pediatric head injuries for specific warning signs in that first 24 hours. A sudden change in the level of consciousness, extreme drowsiness, projectile vomiting, or new seizures, those are massive red flags for increased intracranial pressure. Section 2, musculoskeletal traps. Let's break down the anatomy here, because pediatric musculoskeletal presentations differ wildly from adult orthopedics. A newborn actually has up to 300 bones, compared to an adult's 206. Because their bones are more porous and pliable, they tend to bow rather than break cleanly in half. Plus, a child's ligaments and tendons are actually stronger than their young bone. So when a compressive force hits, like, say, falling on an outstretched arm, the bone is way more likely to sustain a torus or buccal fracture. And get this, their periosteum, that's the sheath covering the bone, is incredibly active. It's constantly making new bone and supplying blood, which means they heal so much faster than adults. Okay, here is a classic prioritization trap. Do not get these two confused on test day. A sprain damages the ligaments, usually from a sudden twisting or overstretching motion. Think of a teenager rolling their ankle on the soccer field. A strain, on the other hand, is an injury to the tendon or muscle itself, and that's often from repeated overuse movements over time. But here's the catch. Regardless of which one your patient has, your immediate nursing priority is exactly the same. You immobilize the area to prevent further damage and then hit it with the Price or police protocol to minimize that soft tissue swelling. Section 3, congenital defects. Let's lock in some visual memory anchors for structural anomalies. First, the Pavlik harness. This is the gold standard orthotic treatment for developmental dysplasia of the hip, or DDH. This is a huge test focus because it's incredibly subtle. Infants are often completely symptom-free at first. Basically, if mechanical or positioning factors in utero cause the hip joint to form improperly, it's going to require a dynamic ultrasound before 6 weeks of age to get an official diagnosis. The harness just keeps those hips abducted and flexed to gently guide proper joint development. Now compare that hidden dysplasia to the very obvious presentation of congenital clubfoot. The dramatic inward turning of the foot is unmistakable. But fortunately, we have a highly effective non-surgical treatment path for this. It utilizes serial casting. So a new, slightly more corrective cast is applied every week over a period of about 4 to 6 weeks. This gently stretches those ligaments and gradually realigns the foot.
Pay very close attention here because this is a massive clinical safety alert. If an infant presents to the ED with fractures at multiple varying stages of healing, your first instinct might naturally jump to suspecting child abuse. But wait, before you make that devastating assumption, you have to look closely at their eyes. Do they have a bluish tint to the sclera? If they do, it could actually be osteogenesis imperfecta, better known as brittle bone disease. These babies have bones so fragile they can fracture literally just from being picked up. So your nursing priority instantly shifts to providing incredibly gentle, meticulous care.
To visually anchor another crucial congenital defect, think about how myelomeningocele presents in spina bifida. The spinal cord, cerebral spinal fluid, and the meninges completely protrude right through an unclosed portion of the baby's spine into a sac on their back. Protecting the sac from rupture and infection before surgical closure is, without a doubt, your absolute highest priority. Section 4. Mini NCLEX scenario. Let's test your pattern recognition with a quick pause and think scenario. Based on the visual anchors and clinical cues we literally just covered, if an infant presents to you in the ED with a bulging fontanelle, downward deviated eyes, and noticeably low muscle tone, what is your primary clinical concern? You completely nailed it. If you said hydrocephalus, those are the exact textbook hallmark signs of increased intracranial pressure from cerebral spinal fluid building up in a baby's skull. Recognizing this pattern early means you can quickly prep the family for the likely surgical intervention, which, as we saw earlier, is a VP shunt. Section 5, rapid recap. Let's bring it all together. Seriously, lock this mental table into your memory. When you see floppy baby, instantly associate it with botulism. And remember, absolutely no honey under 1 year. Got bluish sclera mixed with mysterious fractures? Link that directly to brittle bone disease. Prioritize incredibly gentle handling and make sure you rule out abuse first. And finally, for febrile seizures triggered by a sudden spike over 38 degrees Celsius, you want to rapidly cool the patient and hunt down the underlying cause. By maintaining this specific priority mindset, you are doing so much more than just memorizing random facts for a test. You're learning exactly how to be a competent, critically thinking, and above all, safe nurse. So I leave you with this final thought. Armed with these visual anchors and safety alerts, what critical cues will you look for first in your next pediatric patient? Keep asking yourself, what is my priority? And you are going to do fantastic. Thanks for joining us for this explainer.